Hello everyone. Today I'll be discussing postmortem magnetic resonance imaging in the pediatric population. I am Dr. Sanjay Prabhu, a pediatric neuroradiologist working at Boston Children's Hospital and medical director of imaging informatics, and also the assistant professor of radiology at Howard Medical School in Boston. In this talk, I will discuss postmortem imaging with special emphasis on MRI in children. The topics that I will discuss include why is postmortem imaging important, some clinical indications for postmortem imaging in perinatal and childhood deaths. I'll discuss some of the imaging modalities that are used, the pros and cons, and specifically discuss postmortem MRI with regard to the sequences used, appearances of anatomy and various pathologies, use of contrast agents, and some limitations of postmortem imaging as opposed to pathology. I'll also discuss some practical tips for postmortem MRI, including how to screen the patient preparation and positioning, workflow requirements, scan optimizations, and some tips and tricks to improve the quality of the study, and finally discuss some questions about costs for the study as well in different countries. Why is postmortem imaging important or relevant? Overall autopsy rates have shown a significant decline across the world, with neonatal and infant autopsy rates currently at around 30% or lower. This is well below national standard recommendations of 75%, and this means that large amounts of information that could be used to counsel parents about future pregnancies and contribute to epidemiological studies regarding infant deaths is currently not available. Several studies have also shown a 10 to 25% error or discrepancy rate between what clinicians think is the cause of death and the findings of a full traditional autopsy, with error rates as high as 50% in medical certificates in stillbirths. These errors may be attributable to the infrequency in which traditional autopsies are performed, and there continues to be little informed support available for parents about autopsy following stillbirth. Low autopsy rates can decrease reliability of cause of death statistics, and is an important quality assurance measure in healthcare. In this scenario, a less invasive approach may be more acceptable. Imaging-based autopsies are increasingly used now in perinatal and childhood deaths as an adjunct or alternative autopsies. Imaging-based autopsies can be a pre-autopsy screen and can guide the pathologist in performing autopsies of a particular area or organ in a directed manner. These kind of autopsies performed using imaging can have a role in parental bereavement, genetic counseling, and planning of future pregnancies. Comparing postmortem imaging-based autopsies to pathology-based autopsies nowadays can be judged in the terms of availability of radiologists versus pathologists. Obviously, radiologists are more in number and more easier to find than pathologists who are trained in infant autopsies. Also, the postmortem imaging is augmented by telemedicine techniques, which means you can scan a patient in one location and the studies can be read in another location where a specialist radiologist is able to read the studies. Also, this enables permanent documentation and meticulous re-examination of data when the child has passed away, but you still have all the information on the imaging studies, and more data comes in terms of genetics, etc. And then that kind of correlation can be made between the clinical findings, pathological findings, and the imaging studies, which are a more permanent record of what's happened. Now let's discuss the clinical indications for postmortem imaging. Postmortem imaging has been used in fetal, neonatal, and pediatric age groups. The definitions of types of pediatric death have been elaborated in this paper by Arthur et al. In 2015. So late fetal loss is when the child is delivered with no signs of life between 20 and 23 weeks and 6 days of gestation. Termination pregnancy is when you have induced delivery with or without feticide. Stillbirth is delivery without signs of life after 24 weeks of pregnancy. A neonatal death is death of a live-born baby occurring within 28 days of death. Early neonatal death is death of a live newborn occurring within 7 days of birth. Perinatal death is stillbirths and early neonatal deaths. Then postnatal deaths are occurring between 28 days and 1 year of age. And then childhood deaths are after the age of 1 year up to 16 to 18 years, depending on the various countries. So the indications of postmortem imaging in these various age groups include things like forensic pathology, termination of pregnancy, stillbirths and neonatal deaths, sudden unexpected deaths in childhood, and also to use to guide biopsy or directed pathological exam. And in some institutions is used as a post-procedural autopsy for in-hospital deaths. And the brain, abdomen, and heart are the most investigated organs pretty much around the world. Postmortem imaging can aid in the determining of cause of death when the cause is uncertain or requires further investigation. And typically the areas that we are looking at are things congenital anomalies, brain malformations like tumors, brain malformations, tumors, and ischemia, and metabolic disorders, traumatic injury, and postmortem imaging is also used as part of research and epidemiological studies. Let us now discuss the imaging modalities used for autopsies. For several decades, autopsies were confined to using X-ray and X-ray-based techniques. So you could use X-rays, for example, to determine bone age, to identify skeletal dysplasias, look for skeletal fractures in patients with birth trauma, osteogenesis imperfecta, look for any retained foreign bodies, and catheter trajectories in patients after in-hospital deaths. Here's an example of a child with a condition called dystrophic dysplasia. This is a genetic condition that causes dwarfism. In this child, you can see that the ossified bones of the hand appear abnormal with small metacarpals. Some of these have a delta-shaped configuration. The thumb here is abducted, and the first metacarpal is really small, giving an appearance called a hitchhiker's thumb. On the X-ray of the chest here, you can see this has a bell-shaped appearance, and some of these bones in the spine are also abnormal. This is a child with dystrophic dysplasia, as I mentioned. The other modality that was used for many years and still used is ultrasound. You can use ultrasound to assess the prenatal diagnosis, look for fetal demise, and then you can diagnose cerebral hemorrhage in children, in neonates, and you can use this for directing biopsies of particular organs and guidance for catheter placement for contrast administration in postmortem studies. Here's a child who had, as a fetus, who had died at 23 weeks of gestation, and on ultrasound before death, the child had been shown to have a left-sided congenital diaphragmatic hernia, unilateral cleft lip and palate, and bilateral echogenic kidneys. On this postmortem study, you can see there's this large diaphragmatic hernia on the left side, as predicted by the pre-mortem scanning. The brain has a slightly smooth gyration pattern, which is consistent with gestational age. The conus medullaris here in the spinal ultrasound done post-mortem shows a low-lying conus medullaris, and the kidneys are echogenic. Let us now discuss the other imaging modalities used in postmortem imaging. CT and MRI are now the main workhorses of postmortem imaging around the world in pediatric patients. Postmortem CT is used in forensic practices because it has better spatial resolution, identifies fractures and hemorrhages effectively, is better for identifying coronary artery calcification in adults, is more accurate imaging technique in adults than MRI, and is less susceptible to postmortem changes like gases and other postmortem abnormalities which can cause artifact on MRI. It's quick and readily available around the world, and there are no significant safety issues. For example, there's no problems with wires or pacemakers, etc. And it's more economical. However, MRI provides better soft tissue contrast resolution compared to CT. It can differentiate between various types of soft tissue and is particularly advantageous when it comes to evaluating the brain, spinal cord, and other organs with complex anatomical structures. The spatial resolution of CT is higher, but MRI is helpful, especially when you have patients who are postmortem patients who have myocardial infarction, for example, and CT cannot help you in those scenarios. The disadvantages of MRI is that longer exams, more operator dependent, and the safety issues to avoid damage to tissues, even in the postmortem stage, which is important to preserve the in infants or the child's body for the parents. And also it's more expensive and it's harder to obtain time on the MRI scanner in most institutions. Let us now talk about the various imaging sequences that can be used in postmortem MRI. In general, based on current practices around the world, the basic clinical standard protocol includes T2 weighted images in 3 orthogonal planes, axial, coronal, and sagittal, a 3D T1 weighted isovolumetric sequence so you can reconstruct into multiple planes, and a susceptibility weighted image or a T2 star weighted imaging study in cases with possible hemorrhage. These imaging parameters can then be adapted to cover the whole body in a single acquisition, so the brain and torso in a single acquisition in a young infant, or divided into separate brain and torso like a thorax and abdomen acquisitions determined by patient size. This whole study should be achievable in about 30 minutes. So here you have some parameters here. So 2D T2 TSE, a turbospin echo sequence in 3 planes, 3 millimeters, ideally no gap, with concatenations or echoes, 2 echoes, and a voxel size of about 0.8 to 1 to 3 millimeters. And this takes about 1 to 3 minutes each. And you can have vestibular images, again 4 millimeters with no gap, with a voxel size of 0.6 or 0.6 by 4 millimeter, and then a body sequence, a 2D TSE sequence in 3 planes, or and also a 3D T2 TSE in 6 to 7 minutes, and finally the T1 weighted sequence to cover the brain and body in about 2 to 4 minutes. Some dedicated cardiac sequences can also be obtained, as we did in our study here published in 2015. We obtained some T2 and T1 T2 weighted images, axial T2 short axis, 2 chamber and 4 chamber images, and a spin echo 3D isotropic image for patients with congenital heart disease. The consensus clinical standard sequences have been determined by a European Society of Pediatric Radiology survey and this consensus group here, and they have very similar protocol with a T2 weighted sequences of the brain, T2 weighted sequences of the body, and T1 volumetric sequence as I described earlier. This is a useful document to refer to if you are establishing a new protocol, because this has most of the parameters that have been found useful by survey participants and also around in the USA and other countries. Let's talk about contrast administration. Generally, contrast administration is not recommended currently for MRI. However, if you're performing concurrent postmortem CT with contrast, then it's very important to remember to perform MRI first to prevent the introduction of air into the vascular system. MRI is useful for examining cardiac valves and heart chambers, and CT angiography images can be used to look at the systemic veins, aorta, and coronary arteries. CT angiography can also visualize the pulmonary thrombus better. So in this study that we published in 2015, we looked at both CT and MRI in patients with congenital heart disease who had died in the hospital and showed that there was good correlation between the CT and MRI findings with the pathology findings. It's a paper worth reading. Let us talk about the appearance of various organs on sequences after death. This is a postmortem study of a term infant who had died 24 hours after birth. She was imaged about 3 hours after death, and this scan here shows a right-sided parietal subdural hematoma. They can see here there is a hypertrophied right ventricle and pooled blood in the dependent portions of the heart. And on the brain images, susceptibility brain images show stagnation of venous blood. On the sagittal images here, you can still see the pituitary gland is normally formed. You see a bright thyroid gland, which is normal in a neonate. You can still see the brain structures, normally formed corpus callosum, cerebellum, brainstem, and on T1-weighted images here, you can see the normal basal ganglia and thalami, internal capsules. And the sagittal and coronal images of the abdomen and chest, you can see the hypertrophied right ventricle here, the liver, and the abdominal structures quite well. You can see some of the edema here in the soft tissues. Some of this is postmortem change, and the lungs can be very hard to determine any abnormalities in after death because of the venous congestion. Here's another study here of a patient with it was a child who had died in hospital after a congenital heart disease operation and some complications. The child had an infarct and underwent postmortem imaging. Here's the postmortem MRI of the brain. You can see there's an infarct here in the right posterior parietal lobe. You can see it's on the T1-weighted images. You can see a T1 hyper intense area here. And this is matched clearly with the pathology specimen here. You can see that there's an infarct in the same location. So you can see how the imaging study can be an adjunct to pathological imaging and can direct the pathologist to a specific area in the brain. The next case I have here is a 3-week-old infant with microcephaly who had died from pulmonary and intestinal complications. On the postmortem imaging study of the brain, you can see there's a very diffuse abnormality. There's diffusion restriction throughout the cortex and cerebellum, and these axial images through the brain here show that the septum pellucidum is absent, subseptal leaflets are absent, and on the sagittal images here, you can see there's like a prominence in the hypothalamus, suggestive of a hypothalamic hematoma or a midline fusion anomaly, and there were fused low-lying fornices. The thalami were closely opposed. You can see them in the midline here, but there was no evidence of suboptic dysplasia or schizencephaly. And in this cerebellum, you can see on the T2-weighted images here, you can see small areas of hypointensity consistent with small remote microhemorrhages. Here's another child who had heterotaxy with very complex anomalies. This is a specialized cardiac sequences that I described in the sequences section earlier. This child had short axis T2-weighted images, showed a Shano shunt entering the right ventricle, that is over here, and here's a pathology correlate of the Shano shunt. On the bottom panels, you can see there's a common atrium, and there is a double outlet right ventricle, and a small right-sided aorta, and leftward pulmonary artery. These findings were then confirmed on autopsy. Here's the common atrium again on another slice of the postmortem MRI. You can see the pooling of blood here, which shows you this is a postmortem scan. Here's another example of a cardiac postmortem MRI. This is a child who had severe aortic stenosis, had a very abnormal mitral valve, and developed endocardial fibrinostosis, which is basically abnormal tissue forming along the margins of the ventricle, and had undergone a Ross Corner procedure for treatment of aortic stenosis. On this short axis slice image here and a 2-chamber left view from T2-weighted MRI scan, you can see here's the site of the ventriculotomy where the surgeons had gone in to try and take out the endocardial fibrinostosis. Unfortunately, there was septal hemorrhage, and that's shown here by the hyperintense areas here along the hypointense areas here along the septum on along the right side here. In the left ventricular cavity, you can see this hyperintense rim, and this is that endocardial fibroblastosis that the surgeons were trying to get rid of. And on the pathology specimen, which was correlated with our MRI, this ventriculotomy here on the MRI is here shown opened here by the pathologist here. This is the opened left ventricle. These areas here along the margins here, this kind of a thickened surface here is the same as this endocardial fibroblastosis that you can see on the MRI. And here's again the right ventricle with areas of subtle hemorrhage. Let's look at another case here which illustrates the limitations of post-mortem MRI and also introduces a concept of high-resolution post-mortem MRI. So this is an infant who presented with early onset epileptic encephalopathy and respiratory depression, which was unexpected in terms of the medications and the seizures. So there seemed to be like two independent things happening in the same child. The conventional MRI, which is done pre-mortem here, did not show a lot of abnormalities. There was probably some mild T2 hyperintensity in the dentate nuclei. And if you look at the brainstem here, really the resolution, at this resolution, you don't see abnormality as such. Again, you can see the brainstem here on an axial image, and I'll pay particular attention to these areas around the inferior olivar nuclei, but it's really hard to see much detail on these scans, which are done as a clinical study. However, when we did the postmortem study, we actually got the brain and then scanned the child's brain in a special solution using a special holder, and this was done for a 24-hour period to get these really high resolution images overnight. And you can see the detail of the hippocampus here. You can see the various layers of the hippocampus, and this is a scan through the brainstem. Here's the inferior olivar nuclei, and here's the same thing blown up. So you can see the hippocampi here, and on the hippocampus, you can see that there is abnormal appearance of the dentate gyrus. This is this layer in pathology here, which is called bilamination, where you have a splitting of the layers of the dentate gyrus. And this has been shown to be a finding in patients with sudden infant death and a cause of seizures. This is seen in both hippocampi. And then surprisingly, in the inferior olivar nucleus here, you can see here, there was this very hazy looking appearance on imaging, and we weren't sure what it was. But when we looked at the pathology, here's the inferior olivar nuclei. At the same level here, you can see this is supposed to be, this is something called the arcuate nucleus, should be present here. This is a normal patient, a normal specimen of inferior olivar nucleus here. And here you have these blue areas here, which is arcuate nucleus. And you can see there's almost complete absence of this arcuate nucleus here. And this is required for the normal respiration, respiratory centers. So this was actually an important finding. And the child underwent imaging study, post-mortem, and then finally all the genetics came back. And then we found mutations in these NRXN1 and NRXN2 genes. It's called a digenic mutation. So this is basically a condition where you have more than one genetic mutation, one from a mother and one from the father, and this is required to produce a severe disease, which typically is not lethal. But in this condition, you have both epilepsy, which came from the one of the genes from the mother, and the respiratory depression from the father's gene, and this caused a severe abnormality in this child. So this was an example of high resolution imaging in an infant. Let us now discuss some of the postmortem changes that are very important to recognize in children who have been imaged after death. These postmortem changes can mask or alter the anatomy present at time of death, especially things like ischemia and heart abnormalities can be masked. These can evolve and increase following death, and so it's important to make sure that you image soon after that, or as soon as death as possible. The sedimentation of blood products due to hemoconcentration and putrefactive gas that can develop in various parts of the body can cause artifact on MRI and limit evaluation. Typically, there is a small amount of fluid that develops in postmortem patients in the pleural and abdominal cavities. This is just normal fluid and can be hard to distinguish from pleural effusions and ascites. And postmortem pulmonary atelectasis is uniformly present and can be difficult to distinguish from pulmonary pathology, except when it's really severe. Subsequent changes can occur, including autolysis of the brain and solid organs, and this can limit evaluation due to loss of tissue contrast. Again, this is important because to make sure that you image the child soon after that as possible. Also, consider intrauterine fetal MRI as the first step when there's an intention to terminate pregnancy due to a fetal cranial abnormality, as postmortem MRI has been shown to be less accurate for CNS anomalies than intrauterine fetal MRI. Let's just now talk about some tips for ensuring a safe and clinically useful MRI. As we discussed, the postmortem changes start developing soon after death, so make sure that the MRI is performed as soon as practical post-death. Very important to obtain informed consent if still in the research phase, and if it's a clinical study, again, it's important to inform the parents and the caregivers of the procedure at all stages. When the child is brought into the MRI scanner, it's again just like any other MRI study. Make sure you look at all the lines, tubes, cannulae, indwelling metal implants, etc., to avoid damage to the body from the MRI. It's very important you remove the external metal and clothing that may cause artifacts and degrade the images. Make sure you use MR-safe central venous catheters, endotracheal devices, and chest tubes, and these should be left in place. If there's anything which is not MR safe, then those should be taken out and recorded clearly in the medical record. The child should be transported to the scanner, the body in the MR compatible body bags, and you should consider scanning after regular hours if you're using like clinical scanners, and then meticulously clean the scanners after the scan's completed. Typically, we keep the arms at the side when you image, and you choose the smallest coil that will fit to maximize the signal and obtain as much coverage as possible. Finally, make sure that after the scan is completed, you arrange for safe transport of the body back from the scanner, and then clean the room per local regulations after. Let us now talk about the cost of the procedure. Globally, I don't know of any centers that provide a fully funded routine service for pediatric postmortem MRI. Majority of cases are done on a case-by-case basis, and the costs are absorbed by the hospital or departmental budget. Some centers in the UK receive some funding as part of a UK postmortem funding stream, that is a portion of the government fee-for-service payment for all pediatric or perinatal conventional autopsies. In the Netherlands, this government funding for unexplained or unexpected deaths of children from infancy to their 18th birthday. Locally in Boston, where I work, postmortem studies are done on a case-by-case basis. There's research funding available for a cardiac study when we have for a few years, but we no longer have that. And fetal postmortem scans are the cost absorbed by the hospital. We do have something called the Roberts program, which is a program for investigating deaths occurring as a sudden death in childhood. And in this program, parents and families are offered a research study to image any organs of the child who has died, and also the siblings and the parents looking for a cause of death. In fact, one of the cases I showed you with epileptic encephalopathy was part of this program. So to summarize, we have discussed the role of postmortem imaging in children, some clinical indications for postmortem imaging in perinatal and childhood deaths, discussed various imaging modalities like X-rays, ultrasound, CT, and MRI, the pros and cons of MRI and CT, Postmortem MRI, the sequences used, the appearance of anatomy and various pathologies on MRI, the fact that we don't use contrast agents typically in MRI but can be used in CT, but very important to make sure that you do the MRI first and then inject the contrast for CT. Some limitations of postmortem MRI. I showed you the case where the pathology was much more instructive as opposed to the both the pre-mortem and the postmortem MRI, in spite of having high resolution scanning. I gave you some practical tips for postmortem MRI, including patient screening, make sure that the scanning is safe, some patient preparation tips and positioning, the arms on the side, for example, the workflow requirements as to when to image the patient, how to get the patient to the scanner, safely transport the patient back and forth from the scanner, and then also some scan optimization tips and tricks, and finally the costs of postmortem MRI in different institutions around the world. Thank you for your attention, and hopefully you learned something from this presentation.